Hello, everyone. Welcome back to the Medical Teaching Podcast for both teachers and learners. Today, I'm going to be talking about something that I have called reverse shadowing. So, reverse shadowing is a term that I have used to describe how, in shadowing, of course, the learner is shadowing or watching the attending physician. In reverse shadowing, the attending physician actually watches or shadows the learner, the medical student or resident. And you might say, well, why the heck would you do that? So the reason why I would do that is because at the point of care, a lot of times it's actually, that's the best time for our learners to learn. And so a lot of times our learners don't know what they don't know, or they don't know what they're doing. They don't realize what they're doing because they're doing it unconsciously or because that's the way they were always taught it. Reverse shadowing allows us as the teachers to have a chance to directly observe what they do in real time and be able to give real time feedback to them. It is such a great exercise and thing that I've been doing actually for the past 8 years or so. And I have found that my learners are able to benefit greatly from that. And so I'm going to talk a little bit about how it can work and how it can be helpful. So I already talked about shadowing in the last episode. So how to make shadowing a little bit more successful and more optimized. So for reverse shadowing, the most important things is for us as teachers to be observant and to pay attention to what our learners are doing and to watch them directly and then to actively give them feedback and to have the attitude of, okay, I'm going to speak my thoughts out loud, what I see, what I observe. I'm going to speak it out loud, and I'm going to speak it out loud at the point of care. And so for my learners, a lot of times when they take a history, they'll sometimes ask questions that our patients answer their question, but it's not what our learners or our residents, physicians, or medical students were intending to gather. And so then they have to change course. They have to ask a different question, right? And so giving them feedback on that. Okay, do you see how if you ask a patient, hey, did you have any fever? And the patient says, yes. And they say, oh, okay, well, when did you have a fever? 5 weeks ago. That's not going to be helpful, right? You want to know in the past 3 days, right? The past 3 days, the patient has been having symptoms. In the past 3 days, have they had fever, right? And if they did, was it measured? How high did it get? These kind of things, right? So being able to tell our residents right then and there, okay, so now do you see? You're not going to just ask your patients, did you have a fever? You're going to ask them in the past 3 days or in the past however long the HPI is referring to, in the past time span, did you have X? Did you have Y? And so helping them to be able to improve their history taking skills, their, again, physical exam skills, being able to watch them in real time, being able to give them real time feedback, watching how they do their neurologic exam. For instance, if they're doing their neurologic exam and they're doing their cranial nerve exam, but then they forget to do the motor component of cranial nerve 5, or if they don't test cranial nerve 12, by having the patient, stick their tongue out and move their tongue back and forth, to the right or the left. These are things that you can catch by being at the bedside. And, these are things that, again, our residents may or may not realize that they're missing. So physical exam skills, and then really importantly, during the assessment and plan time, when our residents are basically telling their patients, okay, you have such and such diagnosis, or you have such and such problem. And so if they know the problem, we're going to, this is your diagnosis, this is what's going on, this is what your diagnosis means, and this is the plan we're going to do. If your resident is using medical jargon, this is the time that we can give them direct and active feedback right then and there. If our residents are talking too fast, right, or if they're talking too soft, or if they're not explaining things in a way that our patients are able to follow them, watching the patient. can help us see whether they're getting through to their patients or not. And then we can say, okay, see, try teach back with your patient. Ask your patient to teach back to you what you just explained to them. And if the patient's able to do it, awesome. Then I guess after all, they were able to get through. But if the patient's not able to teach back, then being able to say, okay, see, this is a perfect learning opportunity for you to realize that if you communicate in that way, it's not going to be as effective as if you slow down a little bit, think it through, and then use non-medical jargon to explain things in simple English to your patient. Then they'll be able to follow you much better. And then if you don't know the diagnosis, you can't figure it out right then and there, to be able to help your residents be able to think through a differential diagnosis, and then having them explain to the patient, okay, so you have such and such problem, you have problem X, and so because of problem X, I'm thinking of diagnosis A, B, C, and D. And because I'm concerned about these diagnoses, I'm going to order tests A, B, and C, and D. Right? And so being able to help your learners to see whether your learners are doing that. Are they explaining it in that clear way? Are the patients following? Is the resident physician talking while looking at his or her phone, or is your resident explaining things while they're typing away on the computer? These are all things that you can help your learner to do differently, right? You can to optimize their patient care, right? You can say, okay, put your phone down, sit down, there's a stool right there, or sit down next to your patient or close to your patient, look him or her in the eye and the family, and then sit down and then explain to them what's going on. Use clear language, speak slowly, explain what you're going to do, why. And then ask them if they've got any questions, and ask them to teach back. That's the biggest thing, right? Because a lot of times as physicians, we say, oh, you've got such and such problem. You've got acute blood loss anemia due to a Dieulafoy lesion in your upper, in the gastric body of in the fundus of your stomach. And so as a result of that, we had to cauterize it, and then we transfused you with 2 units of blood because of the blood loss anemia. And so now moving forward, you're going to be on Protonix and PPI for 6 weeks. And if we say all of that, our patients may have a harder time following than if we were to say, okay, you had some spots in your stomach that were bleeding, and thankfully the GI guys were able to burn it and stop the bleeding, but your blood levels were so low that we ended up having to give you blood. And so you got a couple of pints of blood this morning, so we're going to be monitoring your blood levels in the next couple of days, and also you're going to be on some medicines to help prevent your stomach from having more of those kind of spots, bleeding spots again, and ulcers. Okay, so kind of helping, recognizing and seeing how our residents explain things, and then being able to show them, model for them, to be able to give them an example of how they can communicate more effectively and speak more clearly to our patients, and be able to and then asking our patients, okay, so now that you've seen both versions, which version made more sense to you, and then teaching back, okay, so tell me, what problem do you have, and then what have we done so far, and then what we're going to do moving forward. And so by modeling, then we're able to help our learners move forward and grow as physicians. And we wouldn't have known that they needed that unless if we did reverse shadowing. Now I've heard some residents say, well, I don't really want to, I don't like that because, then you're undermining, my authority as his or her physician. Well, as the attending physician, my response to that is, okay, I understand your concern, but at the end of the day, remember, I'm the attending physician. I'm the physician of record. And so this patient knows that you're here to learn. You're a resident physician. You're here to learn. You're here to grow. And so, again, by introducing my resident and medical student, telling my patient, this is what we're doing. I'm his or her instructor. I'm teaching them, and the things that I'm saying to him or her and correcting him or her or giving constructive criticism is not because he or she's doing a bad job. No, they're doing a great job. But it's to help them move to the next level so that they can be a better physician for you in the future. I have had no patients ever have any problem with that whatsoever. So that's one thing. So at the end of the day, there's no, the undermining thing is not really an issue, because at the end of the day, it's the attending who is liable. It's the attending who's the physician of record. The resident is playing a part of the care, yes, but at the end of the day, the attending has the final word, and I think our patients know that. And if they don't know it, then it's our job as the attending to help them know that, and to help our residents be able to focus on their learning and help them be better and not worry about them being undermined. So I think number 2 is the concern of, I don't want to look dumb in front of the patient. Again, how we do it is of crucial importance, right? If we say, oh, well, how could you miss that? Well, our patients are not going to look kindly upon that, right? But if we say to our resident, all right, so see, that is an easy thing to miss. And so now to look for that, and you'll get it next time. If you frame it in that way, then it will be a positive experience for everyone. And so then another thing is that sometimes people might say about reverse shadowing as well, it's a little overwhelming, to have, or it's a little intimidating to have the attending physician, watching the resident or the medical student while they're in the room. I feel inhibited. A lot of times what I'll tell my resident or medical student, I'll just say, just pretend I'm not there. And if you can't, then that's okay. But just carry on and do things as if I'm not there. And what I've found is that over time, as my residents, as we do it more, as we do reverse shadowing more, that my residents eventually just forget that I'm there, and they just go for it, and they get more comfortable with the situation, and they just do it, and they do very well. And we're able to, and as time goes on and the reverse shadowing continues, then there's less and less constructive criticism, because they're putting into action these suggestions that I'm giving them. And so by the end, I'm able to say, well done, good job. You did a nice job on that. I see you've improved this. I see you've improved on that. Good job. And then finally, the last thing is how to do reverse shadowing, right? Is to not start with having the resident take the whole list at once, right? I start them on the first day that they reverse shadow. Maybe I'll give them 4 patients where they've got to know everything about those 4 patients. 4 is reasonably manageable for the first day, right? They've got to know what's going on with the story, the H&P, the labs, the radiology. They've got to know the assessment, the plan. So, and for 4 patients, but then, tacking on, maybe it'll be 6 the next day, maybe 8 the next day. Depending on the resident, you can move it up faster or slower, but basically ramping up the number of patients that they're responsible for, that we are reverse shadowing, that I'm reverse shadowing them. And so in that way, it's not as overwhelming as they get used to this learning process. So I hope that this is helpful. I hope that you find reverse shadowing to be something useful. You probably have already done reverse shadowing and just didn't realize it. And maybe you've done it in a way that makes sense. I would love your comments and your thoughts about how to make it work best. These are just some of my thoughts about how I've made it work for me and for my residents. I hope this is helpful, and I'll catch you on the next episode. Thanks.